Right, it's time. Hello and welcome to our special series, the ASLM special COVID-19 sessions. And this is session number 7. This is an initiative of the ASLM in partnership with Africa CDC, FIND, ICVIA, the Korea World Bank, and we also acknowledge our funding through UNITAID, as well as our partnership with the Clinton Health Access Initiative to make this a success. My name is Anafi Mataka from ASLM, responsible for our initiatives around accelerating access to diagnostics and integration towards innovative technologies funded by UNITAID, as well as our work in the laboratory systems community of practice funded by the Bill and Melinda Gates Foundation. Today, we want to talk about one of the familiar terms that we have in diagnostics, and that is turnaround time. Usually, we just call it TAT. And usually, this is a benchmark for laboratory performance. Some actually call it, it's a reliable and a reliable indicator of measuring laboratory effectiveness. And this couldn't be any truer when it comes to COVID-19. COVID-19 has one unique feature that we all know: asymptomatic transmission. And as it is coming out from evidence on the ground, symptom-based screening only has failed to detect a high proportion of infectious cases. And therefore, it may not be enough to control transmission in certain settings as being described. Therefore, asymptomatic transmission at the moment could be the Achilles heel of current strategies to control COVID-19. And that calls for expansion in testing to include also asymptomatic patients in health settings. And as you all know, to do this, we need laboratory testing. But for these strategies to be very successful, we need timely action on the results. That is, the results need to be presented in a timely manner in order for us to track the epidemic in real time and implement control strategies. Today, we are happy to have one of our renowned scientists addressing our session today, Dr. Trevor Peter, who is a Senior Director for Diagnostics at the Clinton Health Access Initiative, CHI. He will share insights into strategies to implement fast turnaround time around laboratory testing in order to control COVID-19. Over to you, Trevor.
Thanks very much, Anafi. Good afternoon to everyone, or good morning or good evening, depending on where you are. I think Anafi has given a great overview, so I won't dwell on the initial outline or staging of the presentation, but just go straight into it. So let's see how we... Okay, so first, I think many of us have been, over the last few weeks, have become very familiar with the overall COVID epidemic, and we understand, intimately, because we see it every day, where it currently stands, where the epidemic is, or the pandemic is spreading, and where cases are being found and where deaths are occurring. And so I don't need to dwell too much on that. This slide here just shows, as of a couple of days ago, where the epidemic currently sits. And I think there's one key feature here that I want to point out, in that there is a higher degree of spread that has occurred within the sort of northern hemisphere over the last few weeks, and the southern hemisphere, and particularly Africa, we seem to be at an earlier stage of the spread. Of course, that is those numbers are obviously impacted significantly by the degree of testing and the ability to actually confirm cases. So Africa, we may be at a later stage in the epidemic than this map currently shows. But we know that within the next few weeks, testing supplies will become much more available, and we will see a lot more testing happening across all of our countries, and this map may suddenly start to change. It'll change not only because of the testing, but possibly because not only because of the testing, but also we expect to see a growth in the epidemic within these countries. Just to point out again, as a sort of staging viewpoint, that everyone is concerned about COVID for very good reasons. Its contribution to daily death is from different infectious diseases is growing, and it's, as you can see from this graph, it's sort of rapidly climbing, and are starting to rival some of the more traditional, more familiar causes of death from infectious diseases. This slide shows the trajectory of different epidemics across a range of countries. The x-axis relates to the days after the sort of first few cases, and so everything sort of starts at one point. But the key point about this figure is that you can see that in a number of countries, the epidemic has been growing and continues to grow as of this is from just a few days ago, and is still increasing in a number of countries, particularly in the Northern Hemisphere. You will see, however, the blue line at the very bottom, which represents a familiar case of South Korea, which has been hailed widely as having successfully managed its epidemic. And you can see it, the sort of curve of the graph. For those of you who are familiar with the epidemiology and sort of the nature of epidemics, it looks like that early rise, a lot of efforts in the middle to control it, and then a gradual sort of decrease or decline. And that's what I think, that's really effectively what all countries strive to achieve, a sort of an effective control and then decline of the epidemic. And that's what we call sort of flattening the curve, which has now become a very common term. And this orange peak represents what a classic epidemic can be, and what we have now come to believe will happen with COVID-19 if the disease spread is not unchecked. And so there are a number of preventive efforts that have been undertaken in many countries, and the shutdowns and the close downs and the isolations and stay-at-home orders that have occurred are really related to how we flatten this, efforts to flatten this curve. And the effort of flattening the curve has multiple goals. Of course, preventing death is the number one overall cause. Preventing further spread is another. And it's important to be clear about that. But also, there's a lot of this thinking is also about preventing the overwhelming of health systems, and an overwhelming of hospital beds and ICU units that would make the health system unable to manage the course of the epidemic and its impact. And a lot of that thinking comes from a number of models. Of course, this is a new epidemic, and there's not much known about it, although we're learning rapidly every day. But some of the sort of thinking about its epidemiology has come from some models conducted by a number of different groups, including a group from the Imperial College that a few weeks ago described how through a number of efforts, such as case isolation and closing of schools and so on, and home quarantine, could each have effects on flattening that curve, and when put together, could have a significant impact on mitigating the number of cases and reducing spread. And that's shown by the figure on the left. The figure on the right, however, I think illustrates a very important point that relates to our overall COVID control. And that is, if you look at it, there are a number of sort of pillars there, and the orange line represents a number of different peaks. The first peak is sort of where we are right now, globally, and of course individually by country, in that when the virus starts to spread in a country, before there are mitigating efforts, before there's social isolation and other efforts to reduce the spread, that there is a lot of spread, and a lot of people become infected, and those cohorts of people eventually either have mild disease or they have more severe disease. And that's why you see this initial peak that happens before the control efforts come into place. But then once the control efforts come into place, you see there's a reduction, and that's, that happened in South Korea, it happened in China, and it's happening to varying degrees in other countries across the world. But obviously, and the lockdowns that almost everyone is under right now is pushing that curve down. Of course, when those lockdowns end, the virus, unless it is it's eliminated, and it's unlikely to be eliminated by this current set of lockdowns, because the lockdown is not complete, universal around the world, that the virus will start to spread again. And so it's expected that there will be a number of additional small epidemics that hopefully will be of smaller intensity in terms of their peak, but they will continue to occur, and there may need to be an ongoing either a series of additional lockdowns or a very active surveillance for new cases. And I think the latter is the approach. Well, it's the approach that was taken in South Korea, which I think will probably be the approach that most economies and governments would prefer to take, is that once the current lockdowns end, there would be then a very active surveillance for new infections and very quick action taken to isolate those cases and to limit the spread of the virus. So how does it relate to testing? Well, obviously testing is very important for that active surveillance and an active response, rapid response to identify and then isolate patients that are infected and their contacts. So we test, obviously, when you diagnose someone, you obviously test from and you want to know whether to take care of that patient. And there's several steps that can be taken to ensure that the patient is taken care of, and does not the risk of mortality and morbidity is limited as far as we can with our current health systems and our current drugs and treatments we have. Should I say, current treatments and care that we have? There are no sort of currently widely available drugs, as you know, for COVID. Secondly, for surveillance here from the perspective of identifying new outbreaks. And that relates to the epidemic control efforts, because right now the main tool that we have to control COVID-19 is through classic public health methods of identifying and isolating those who are infected in order to break the chain of transmission. And this is illustrated in the slide, which shows where COVID-19 or SARS-CoV-2 sits within this sort of a graph of the sort of case fatality, or the likelihood of death versus the average number of people that any infected case is likely to transmit to. For every one infected person, how many additional people become infected from that person? And SARS-CoV-2 sort of sits there in that box. The actual numbers is not yet fully clear, because the real case fatality rate is difficult to actually estimate at this point, because the denominator needs to be sort of more better defined. But the key point here from this slide is that roughly between maybe 1.5 to 3.5 people are estimated to be infected from every single case. And for those of you familiar with the concept of reproductive number, the goal of epidemic control is to reduce that number of 1.5 to 3.5 to 1, and ideally actually less than 1. And when it becomes less than 1 on average, then each person infects less than one additional person on average, and the epidemic goes into decline. And so a lot of the public health methods being currently used to control COVID-19 are really focused on trying to reduce how many people each infected person infects. So how do we do that? And as many of you know, we use contact tracing. So I won't go into the mechanics of contact tracing too much, but I think it is important to dwell on it a little bit and to think about where testing fits in within this context. So case identification, contact tracing is our primary tool right now for COVID control. And so that involves identifying people who are infected and then identifying who they may have had contact with. And there are close contacts and there are sort of not so close contacts that I'll describe just now. And the contacts, the key action for after contacts identified is to ensure that they isolate. One doesn't have to test for the contacts, but one has to ensure that they're isolated, and they isolate themselves from additional contacts, and so you prevent the chain of transmission at that point. And if you're successful in your contact tracing, then you can limit the spread of the disease. Now, what is a contact? So a contact is, and I should say that a close contact, a contact that actually has a higher likelihood of have become infected by contact with an infected person, include people who have sort of face-to-face contact with a COVID-19 case within 2 meters for more than 50 meters, people who have physical contact with COVID-19 cases, so direct contact, for example, have been coughed upon, living in enclosed environments such as your family members, because there's a lot of contact in that sort of close environment. You know, being on a plane, for example, very close to a COVID case, or being a healthcare worker, for example, a laboratory worker, handling specimens without personal protective equipment. And this is what defines close contact. And so after there has been close contact, and that's considered high-risk exposure. And I've described a number of what defines high-risk exposure in the previous slide. But there are also contacts that have low-risk exposure, and they include people that maybe have had sort of, haven't been that close to an affected person, sort of maybe have been in the environment, the vicinity for short periods of time, but not necessarily in actual contact, or otherwise had been working with a clinical specimen from a COVID case, but using PPE. And those are considered low-risk exposures. Now, the actions for people who've had high-risk exposure and low-risk exposure, so generally the same, still isolate. So it's really about preventing any of those people who may have become infected from their exposure from passing on the infection. But the degree of monitoring is much more intense, obviously, for the high-risk exposures. And of course, amongst both the high-risk and low-risk exposures, if any of them fall ill or have symptoms, they should be tested. Now, the probability of actually catching infection between high risk and low risk is quite significantly different, and there have been some early studies that have tried to look at this, so certainly maybe more than 10 to 20 times higher risk of transmission if you're a close contact than if you're a low risk contact. In fact, most of the transmissions that have occurred where it's been studied, for example, in South Korea, have occurred, for example, amongst family members. And so contact tracing can be managed in that way in terms of focusing on the close contacts and the public health system, focusing on following up on close contacts. So what does this mean for testing then? Well, obviously we need to test in order to identify cases, and then we need to follow up to identify the contacts of those cases and to help ensure that they're isolated, and then of course follow up on those cases, on those contacts, to look for anyone who might develop symptoms, and then identify and isolate their contacts. And so testing for COVID-19, as you know well, falls into sort of 3 broad categories. The first is general screening, and that's fever detection, usually with a thermometer, ideally a no-touch thermometer. Secondly, the actual screening and diagnosis, and this falls into a couple of different categories. The nucleic acid tests that are currently being used widely, as well as the sort of rapid diagnostic tests using antigen or antibody that are starting to become available, that are also on the horizon, that we hope will also be important adjuncts to our testing programs. And then thirdly, testing for patient management. And this includes tests that can be used to stage infection and figure out who amongst those infected actually will go on to have severe disease, will have lung compromise and hypoxia, and need to be taken care of in a more intense way. And then lastly, of course, testing for surveillance using serological tests to determine the level of infection across the in a particular region or country or the world. And we currently know that the main diagnostic test to confirm infection today is a molecular test. It's a nucleic acid test, because those are the only tests so far that have been shown to have the sensitivity and the specificity required for confirming and diagnosing COVID infection and acute infection. Of course, antibody tests can pick up in a very sensitive and specific way COVID-19 infection in people that are maybe a little bit past the acute phase of infection. And that's important, because if you are to do effective contact tracing, you really need to be able to diagnose people early in the acute phase of infection, because that's when they're infectious, and it's important to identify their contacts at an early stage and to isolate the case and their contacts early, so that the case does not infect many people. And that goes to the heart of the epidemic control of COVID-19. So when it comes to testing, and to the core of this presentation, that there is a need to rethink about how we test. And given that nucleic acid tests are the tests that we currently have, and granted, in a few months there may be, hopefully less than a few months, but we don't have them right now. But soon we may have rapid antigen tests that could be used to diagnose acute infection early, and then allow a very fast reaction and response and isolation of that case and detection of their contacts. But right now we have nucleic acid tests, and as we know, they come in a couple of different flavors. We have laboratory-based platforms, and we have point-of-care platforms. And most of these tests right today involve samples being collected in clinics, sent to the laboratory, testing in the laboratory, results being sent back to the clinics and back to the patients. So I think there are sort of four important rules that I'd like to emphasize in this presentation. The first is, as laboratory practitioners and public health practitioners, is our responsibility to contribute in every way we can to rapidly expand the collection of the specimens from people who have suspected COVID-19 that demonstrate the symptoms. It's important to provide access to the sample collection supplies and collect specimens as quickly as possible, and to ensure that testing capacity does expand, because the numbers of tests needed. And I think in the last presentation, a couple of days ago, a very good presentation on the Africa CDC PACT initiative, and the emphasis really there was one of the emphasis was really around how do we increase testing levels and testing rates, so that we are testing large proportions of the population, people who are falling ill. And that capacity is very important to put in place quickly and to have it expand. Secondly, we need to be able to transport specimens to the lab daily, very quick sample transportation. I'll explain why. Same-day testing in the laboratory, and ideally same-day test results. As soon as results become available, they should be sent back to clinics and to patients, ideally the same day. And so, to look at each of these areas in a little bit more detail, firstly, let's consider sample collection. I think, as all of you know, nasopharyngeal samples are considered the gold standard and have been used widely in the past. And as you can see from these figures on the left, they involve quite an intrusive procedure, all the way up the nasal canal, all the way up back, almost pretty much touching the brain, which can be quite uncomfortable and can actually be quite dangerous for the operator of that sample collection, because there could be the release of sneezing and some exposure there. That would constitute sort of a close contact exposure in a way, maybe even despite having PPE, but certainly would put a very high demand on the need for PPE for all healthcare workers to have PPE in order to collect specimens. And so there are other approaches to collecting specimens. Oropharyngeal, which is to the top right, collecting from the back of the mouth. And more recently, they had their newer approaches, for which data suggests that they actually are as effective in terms of yield and diagnostic performance, which is collecting specimens. If you look down to the bottom right, from the sort of anterior nares of the nose, the sort of the nasal area, the nostril area, to collecting in that space. There are also recent reports about later on in the course of infection that saliva becomes also an important collection tool. But suffice it to say that this is an area that I think as laboratory professionals we have to become really well familiar with, and we're going to truly understand all of the different areas and different ways in which samples can be collected and where they can be collected from, and to become and to use that information to guide and advise healthcare workers on how to collect specimens effectively. This is just a figure of there are different types of swabs, and I think it's important that we should become familiar with different types of swabs. The swab on the left is the nasopharyngeal swab. It's more slender, it's a smaller sort of head. It can get right up there to the back of the nose. And the one on the right is more of an oropharyngeal swab, which can also be used for the nasal, the sort of anterior nares or nostril level sort of swabbing. And the point I want to make is it's important for us to become familiar with the different types of swabs and where to collect swabs from, and to recognize that certainly nasopharyngeal, oropharyngeal, and currently, according to what we know, what's called the nasal swabs are also all considered to have equal effectiveness and performance. And for most of the tests actually are listed as appropriate specimens that can be used. Obviously, the nasal swabs could potentially enable self-collection, which would allow us to get to limit the amount of PPE that healthcare workers require. And there are also additional innovations coming that will include dry swabs that'll make it samples sort of easier to ship as well and to handle. So getting back to the point about the potential for rapid scale up of testing demand, and in the coming weeks, we could see a dramatic increase in COVID cases, particularly as countries start to come off their lockdowns, and we could start to see the virus spread again. I mentioned earlier that we've got a rapidly scale-up testing capacity, and currently there are a number of different companies out there that have tests and they have instruments on which to run these tests. And here I'm talking about nucleic acid testing platforms, and there's some familiar names, familiar companies that have been involved in the fight against HIV and TB and other diseases that have for which many countries have an established infrastructure. These machines don't only test for HIV, only for TB. They test for a number of different diseases, and almost all of them will test for COVID-19. And so our first priority should be to leverage the capacity that we have on these machines so they're quickly available. It's very difficult today to get hold of a new machine because there's so much demand on new machines, and simply they often can't be shipped even or delivered to countries because of constraints on the global transportation and courier systems and so on. So we have to use the instrumentation, the capacity we have. And the good thing is that certainly across our continent, we have a lot of machines set up. And certainly globally, an estimate has been made that over 15,000 instruments, I'm talking about both automated PCR instruments as well as manual PCR testing, which is important from companies like BGI and Thermo Fisher. There's a lot of capacity already in countries to run COVID-19 tests, perhaps over 20 million tests per week capacity. So a lot of available capacity in a lot of countries. However, when you look at the actual testing itself and how it's performed, I think many of you will be aware that currently nucleic acid testing is not a fast business. It's not a fast operation. It doesn't happen very quickly, except of course where there are rapid point of care machines that give results the same day. But for the most part, and these bars represent, if you look on the left, it's sort of days after sample collection to result return, represents sort of the average time it takes for results to get back when they're sent from a clinic to the laboratory. And we currently do nucleic acid testing obviously perhaps with sort of less pressure, in terms of timelines, but we do this for viral load, HIV testing, and some of this is also for TB testing, even on point-of-care machines. Sometimes the turnaround times are long, but they're sort of, they're more leisurely in a way, and sort of more what I would sort of call maybe sort of peacetime, even though they shouldn't really be peacetime, turnaround times, but they're slower than they could be. And of course, in the context of COVID-19 epidemic control, where you want to identify cases early and quickly and identify contacts, it's not useful if the test sample, the test result comes back, say, after a month or 2 months or 3 months. It's perhaps easier to manage that and to have long turnaround times when you have a standing population of HIV patients on getting their viral loads. The patient's only going to come back in 3 months' time. And so you only see that patient in 3 months' time, unless, of course, it's a failing patient, or a pregnant or breastfeeding woman or an infant. For many patients, it's okay to maybe have a sort of maybe a 2 week or 3 week or 2 month test turnaround time. It's not as painful. But for COVID-19, that's not going to work. In fact, it would be impossible to have epidemic control with turnaround times of this nature. So what's happening here, and why does it take so long? I think it's useful to dig into the actual information or the data that to try and understand at what point do things break down. So these are actual data here from a number of different facilities, 3 categories of facilities. The first top 6 bars represent the time it takes in the different stages of the whole testing process, from sample collection to receipt in the lab, and the testing process, and then the release of results, and then the delivery of results back to the clinic and the caregiver. And you'll see that there are different sub-bars to demonstrate how long it takes for each of those steps on average. And then the next 3 bars represent sort of each of those individual times for the for clinics that actually have laboratories on site. And this is where the sample is taken from the clinic and walked across the campus of the hospital or across the building of the hospital, to the laboratory. The lab does the testing. And then the bottom one is where there's point-of-care testing on site. And so you can see that certainly for facilities that actually ship maybe a few miles or a few hundred miles potentially to the laboratory, there's a long turnaround time. And it can take, in this case, this is actually faster than the previous graph, but this is in a country that actually has relatively fast turnaround times. It can take days or weeks to get the result back, even in settings where the lab is on the same site as the hospital. So the transportation maybe takes about 10 minutes to walk across. And part of the reason for this is because of batching, because samples are batched. Sometimes at the clinic, sometimes they involve dry blood spots, and this is for viral load and for early infant diagnosis. They're batched, HIV viral load and early infant diagnosis. And then even in the lab, the samples are batched and they're scheduled for testing. And then results also get batched and get ready for them to be picked up, and then sort of hand couriered back to the clinic. And even in the clinic, there may be sort of batching results, and then they're filed into patient files and so on. So there are lots of delays as throughout the entire process. But when you break down as to where most delays are occurring and what's driving it, there are a number of key drivers. And two of the biggest ones involve result return. The long delays, well over 50% of the delays related to just getting the result out of the lab and back to the clinic and getting the result in front of the patient, in front of the clinician. There are delays in terms of sample transportation delays related to batching before samples are shipped, and there are delays in labs. Just like I said earlier about batching samples before they're tested, and so on. So there are opportunities, I think, to address all of these. The ideal scenario for COVID-19 testing with the current technology we have, and recognizing until we have a rapid antigen test, we have to do testing with much faster turnaround times. And so the top 3 bars in this slide just illustrate sort of a 1 to 2 day test turnaround time. That should be the goal. That should be the target, compared to maybe an average of sort of 30 or so odd days, with many days spent at each step in the testing process. We've got to try and move to a 1 to 2 test day turnaround time, as opposed to a sort of 20, 30, or 40 day test turnaround time. Now that may sound unreasonable or too much of a change, but actually, for many of you who actually run labs, know that is entirely possible. And granted, you may feel that some of this is out of your control, but I would say that yes, that's partially true. Some of it actually, you can become a champion for fast turnaround time, and you can have an impact, not only in the testing turnaround time in the laboratory, but also in getting fast sample delivery, as well as fast result delivery. It is only possible to achieve effective contact tracing if we have 1 to 2 test day turnaround times. In the United States and Europe and other countries, when testing first started, the turnaround times were terrible. They were days or weeks before, and sometimes tests didn't even come back at all. And those countries have also learned the importance of shorter turnaround times, and through a lot of effort, test turnaround times have been reduced. In some places, they're still long, days or weeks to get results. But in many places, it's now come down to between sort of 1 to 2 to 3 days. Still not ideal. The ideal is, of course, immediate. And I'll explain why in a minute. But or say immediate the same day within a matter of minutes or hours. But with the current technologies, we've got to focus on trying to reduce this test turnaround time to 1 to 2 days. So what's involved there? What does that entail? Well, firstly, transportation of samples to the lab daily. And this I don't need to explain too much, because I think the solutions here are somewhat obvious. But I'll highlight a few things. Firstly, that we are using a lot of the existing infrastructure. And so, for example, there's a lot of existing viral load infrastructure or TB testing infrastructure in countries that has existing sample referral systems. And so we have to leverage those, but we have to put them in steroids, so to speak, because ideally, when a sample is collected from a suspect COVID patient, that sample should be in the lab, transported to the lab the same day. It should arrive the same day in the laboratory. And this figure on the left illustrates that when one thinks about optimized networks, one has to think strategically about where are the labs and where are the clinics, and create the routes and map out those routes, and figure out how can samples be delivered the same day from clinics that the laboratory services. And that's an exercise that, as laboratory professionals, we should be doing. We should be looking at all the clinics within our footprint from one particular lab, and figuring out how can I get samples from that clinic to the laboratory the same day. What are the mechanisms for doing that? And then pushing to try and ensure that happens. Sometimes it will involve a few different hubs for the more distal sites, but I also want to emphasize that COVID-19 transmits well in high density areas. So much of the early transmission may start occurring within capital cities and larger cities and towns. And for those sort of aggregations of higher populations of people, it may be easier to solve the transportation challenge and get samples quickly the same day from nearby hospitals and health facilities to the laboratory. Secondly, testing the samples the same day. So what does this mean? I think if you think about many of the existing instruments or testing platforms, whether they're manual extraction PCR systems such as Daan or BGI or Thermo Fisher, or automated machines like Abbott or Roche or Cepheid, they have variable throughputs depending obviously on the type of instrument you have, whether it's a GX4 or GX16, for example, or a 6800 or 8800. There are different throughputs for the machines, and so there's variability there that one can look at. But it's also possible to increase obviously your throughput by extending the workday and having a longer shift. And it doesn't necessarily mean that one has to be working 24 hours. You can simply have an extra 4 hours from, say, 5 o'clock through to sort of 9 o'clock, sort of an early to mid-evening shift that could increase the throughput of a laboratory by at least 50%, sometimes more, by adding an additional run, and then setting a run that runs overnight. So that's something to look at. And for many those of you already working out, I'm sure you've solved this problem on numerous occasions. Where samples arrive say by lunchtime or just after lunch, they're separated in the sample processing room and prepped for running on the machines, and they can go on the machines the same really in the afternoon. And there's a run that happens, and perhaps that run comes off 3 or 4 hours later if you have an evening shift, and then you can put a load of second run in the evening to run overnight. And so by the next morning, or even at the end of the first day, you have a bunch of results that can be dispatched. And so that's, if the samples have been transported the same day and the testing is done the same day, it is possible to have this very fast turnaround time, where maybe at the end of that day of the collection, the result actually is out and available. So let's go to where I think some of the biggest problems exist, and sometimes that feels like it's a little bit outside of our control. Is when the testing is done, we've got the samples in quickly from the sites we've tested, and we've got the results in hand, and we need to get them back to the patient. And that involves obviously working closely with the clinics and figuring out how to get results back. And here I think it is going to take particular effort and some focus. Sometimes as laboratories, we sort of say, well, we've done our job, we've tested. Now the result can go back, it's come and collect the result. It's done. It's now in your hands. I think as laboratory professionals, we can take it a step further to ensure the result gets to where it needs to go, both to the healthcare worker, back to the clinic, as well as back to the patient. So I will just sort of flag three modalities for doing this. The first slide here is simply, I guess, the traditional way of doing things, which is, and this happens in many places where the result is picked up by hand. There's a courier person that maybe is a person who drops off the samples, might pick up the results and go back to the clinic. And that person may have been the day before, dropping off the specimens. He comes in the next day by lunchtime or so, at the end of the clinic morning, and he picks up the results that were dropped off for the samples dropped off the previous day. That's an entirely workable solution, and I know it happens in many laboratories. I know with COVID-19, we can probably push to make that happen. And that can work well, because by the next day afternoon, that courier is then back at the clinic and handing the results back to the clinicians and having the patients come in again. Or the patients, inpatients, they get the results immediately. But it does require some management to ensure that that's happening, and some oversight from the lab. I think you should reach out to say, well, I'm getting results back to your courier. Can you please make sure that you pay attention to them, in amongst all the other results that you're giving out, the HIV, the TB, other results that you're sending back to the clinics. Here are the COVID results. Secondly, obviously, many places, there's SMS printers have been used, that they're a bit of an older technology, maybe not as widely used anymore, but there are ways to get results back electronically to healthcare workers, to the clinic. And that's an instantaneous, as the result comes off the machine and is validated, it then can be shipped back to the clinics, and the clinics can then manage it. And that's simply a way to cut out the time taken for the courier to handle and carry the results back. And then thirdly, the use of either SMS or email or other type of app system to get results back, not only to the clinic, but also to patients. And this is where there may be particular value for patients, because they can be, when they come into the clinic and they have signs, they can say, well, we're taking a blood sample, go home and isolate. Results will come back to you electronically, potentially on your phone. We'll get a copy of the results ourselves at the clinic, but you don't have to come back into the clinic to pick up your results. We're able to communicate that. And that communication could potentially come directly from the lab. It could also be a communication that comes from the clinic, saying, stay at home, no need to come in, but your results are here, it's positive. Can you please isolate, and then we'll follow up with you to do the contact tracing. So I want to just make one last point really about why this sort of rapid turnaround time is so important, and why it is important to try and get a 1 to 2 day test turnaround time. In that, when you look, this is a figure of where COVID-19 or SARS-CoV-2 sits in terms of its incubation time compared to a bunch of other sort of infections that have a range of different sort of incubation times. And the key thing about incubation time is the time before people become clinically ill. But inherent within that is, of course, the question as to when do people become infectious. And I think, as many of you have seen in recent news reports, that SARS-CoV-2 is a virus that is infectious in the person that's carrying it before even clinical signs start. And so this means that that person is infecting already, while still healthy and moving around, potentially infecting the sort of 1 to 3 people on average that COVID-19 cases do infect currently, before they even know that they're positive. Of course, when people become clinically ill, and they may sort of become more secluded and stay at home and isolate, and so the illness actually is a mechanism for isolation. So it is important, nevertheless, given the tools we have, to try and pick up infection early. And so it doesn't help if the result comes back after 10 days, after 20 days, or a month. But it is valuable if it comes back within a day or two after the patients present with fever. And so the ideal, of course, will be a rapid antigen test that can test immediately, and the day the person comes in within a matter of hours or minutes. But with the tools we have currently, we've got to at least try and get results back within 1 to 2 days. There's I think a strong indication from the models that even that would be effective. You don't have to achieve it in every single patient, but if you certainly achieve it in a proportion of patients, you gradually bend the curve and you gradually reduce the opportunity for transmission. And I think some of you may have seen this in recent papers about the possibility of straight after diagnosis. Really what you want to do, the key action is to identify your contacts and then to isolate them. And this is maybe a little bit futuristic, but some countries are starting to explore the possibility of using an app to notify potential contacts of their contact with it, and a suggestion that they isolate. So in conclusion, I think we have to adopt new rules for nucleic acid testing using our laboratories and the way we do testing. We cannot use the rules and the modalities that we've been testing, the timelines we've been testing for HIV and TB and other diseases. We cannot use a sort of maybe a sort of 10, 20, or 30-day test turnaround time. We have to really target a 1 to 2 day test turnaround time. Those of you who are laboratory professionals or run your labs, you know that this is possible. Provided you have the ability to extend out and partner with your clinics to do so. And so I think the bottom line is that that's exactly what we should be doing, engaging with your various clinics and with the other health authorities to make this a new metric. Now I need to expand access to sampling and testing and helping to train healthcare workers on how to collect the right specimens and building your lab capacity. But to ensure you're able to get the same day sample transportation, same day result testing, and same day result return. And to use a sort of 1 to 2 day test turnaround time as a key metric. It should be a national metric that across all the laboratories, that this is something that signifies it's a key criterion for success of the lab in the overall national response to COVID-19. Thank you.
Thank you very much, Trevor. I think that was very informative. Thank you very much for the brilliant presentation. Indeed, we need that metric. At least 1 to 2 days turnaround time will be key for us to catch this disease. Let's quickly jump into questions. I'll take the first one. It's from, so be difficult to pronounce, Fasundana. It says, while the current pandemic is on our face in lower, middle, and lower and middle income countries, due to the disruption of TB care, we can think of long-term consequences. TB won't have a peak and fall as this. It is continuous in India, e.g., daily death rate from TB of up to over 1,000, regardless of COVID, continue. So it's really a comment that we should think of TB as we move on with this one. The second one is from Stephen Balinadi, and he says, do we have an African country with an uncontrolled outbreak situation? And how's the picture, including fatalities? Maybe you can...
So I would say that I don't have an answer to that. I think a lot of that can be discerned from looking at the WHO's website where that is being tracked. As far as it is from reports, of course, a lot depends on the ability to actually identify fatalities as COVID-19 related and to do testing to confirm cases. And as it has been seen in other countries, for example, Italy, death rates, background death rates were maybe 2 to 4 times higher in the last few months than normal, suggesting that there were a number of unconfirmed deaths happening. So that probably is a common feature. But I think that will become, I think uncontrolled epidemics will become more visible in the coming few weeks as testing starts to expand.
Okay. Thank you, Trevor. And the next question is from Alexandre Costa. He says, what if a country does not have the capacity to scale up molecular testing? What alternative approaches could be used?
So don't forget, the purpose of testing is to isolate. And so I think in that situation, and while there may be a lot of debate about this, that if there are people coming in with signs that appear to symptomatic of COVID-19, is for them to isolate and for their contacts to isolate. That's the epidemiological step. The testing is a tool for that, and we should not say the absence of testing should not hold back those actions. It just means that may be relatively non-specific, that a lot of people then have to isolate, and some people that may have malaria, for example, may be overlooked, and that's something that also has to be assessed. Obviously, malaria treatment should be assessed, and there should be a test for malaria. That should continue as normal and other diseases. But the key thing may be to just isolate until testing capacity is put in place, or until we get rapid antigen tests that are more easy to deploy.
Thank you again, Trevor. The next one is from Amha. He says, given the seemingly low prevalence of COVID-19 in Africa, what is the recommendation for introduction of serology test? So
yeah, it's a very good question. As you know, any laboratory professional knows that that serological tests have an inherent gap in, or lack. They don't have perfect sensitivity and specificity. So at very low prevalence, if you're less than 1% in some places, or maybe 1 or 2%, your serological surveys may, the results may actually reflect more the lack of specificity of your test than the actual prevalence of infection. However, it does not mean that one should move forward with using them, particularly in certain target groups that are like frontline workers, healthcare workers, and other critical workers who are perhaps higher risk, and the prevalence may be higher there. So that's probably the place to start. And also in certain community hotspots where there may be higher prevalence, and so the numbers will be more meaningful. I think that's maybe a first step.
Okay, thank you, Trevor. We also acknowledge quite a lot of questions around sample collection. So we have also picked one of a few exchanges here from Stanley Bulime, and Stanley said COVID-19 sample collection should be expanded with priority to border or entry points. and an interesting response from Makune DOD Tanzania, I guess. Thanks, Makune. And he acknowledges that, yes, Stanley, but once you have community transmissions, then it's less about the borders and more about the broader community. Any comments, Trevor, there?
I agree. There are once the infection gets into the community, that's really where the battle is. I think, as seen recently, I think in parts of China, that new cases came from were imported, and so certainly screening at borders is also important. How you screen, of course, is and that particular triage at borders needs to be worked out. How best to screen at borders, because right now there's not a lot of movement, but soon there will be as borders open. And but I don't think it's an either or. I think you've got to consider what can be done at borders to prevent the introduction of new cases, and to also focus on community-based screening.
Thank you. I think the discussion also continued. It also touched on around the issue of antigen tests that you mentioned, and says countries should invest in rapid test kits, preferably based on viral antigen detection, to enable same-day results for broader point or community-based testing. Then along that line, Yomi Newton chipped in and say, how can we get validated rapid tests that can be used at community level and its cost implication? A broad discussion which we also had just a few days ago. You can chip in, Trevor.
Yes, I know the discussion has been had. I'll add that FIND is doing a great job in evaluating test kits. You got to consider sort of where we are. We're literally a few weeks, a couple of months into this epidemic in terms of like the global spread. And so the first test kits, rapid test kits that came out didn't have a lot of validated, patient specimens to confirm or evaluate them on. And so there were very limited number of specimens. And so it was not easy to evaluate these test kits. And some of the early test kits, had to use reagents from SARS-CoV-1 just to be a rapid response. And so there are two things that need to happen. One is the FIND evaluations, which are independent and on good quality specimens. We get a good sense of truth and performance. So you can work out which tests work well and then use those. And then secondly, there's going to be an ongoing evolution of the performance of these tests as test reagents become better and better. The tests, chemistries, become better and better. And we sort of strongly believe that there's going to be probably high quality antibody tests and high quality antigen tests. There will be a question as to how sensitive and how specific they can ultimately be, and that's a discussion that you've covered already, and we can talk about more at another time. But we yet to be seen whether we can get really high sensitivity and really high specificity for both antibody tests and antigen tests.
Thank you. Maybe one more. This is from Mutandu Rugola. As this is becoming a new normal, going forward, do you see the role of quantitative tests in patient management?
It's a good question. I think for patient management, really for now, the focus is on the clinical situation of the patient. And so we know already that there are issues of what we call silent hypoxia within patients, where there's significant lung compromise that isn't necessarily easy to detect. And so one has to use things like pulse oximetry to determine that the oxygen levels in the blood are going down. And so I would put more emphasis on those already available diagnostic tools that help you assess the clinical condition of a patient. Pulse oximetry and other measures of severity, imaging and X-ray particularly could also, and CT scan has been used in the past to help you determine the degree of lung compromise. So I think tests for determining who is more severe and more likely to go downhill. There was a slide I didn't show, which I think, but many of you know that it's only a small percentage of people that actually become clinically ill, and of those, a percentage that actually die. So focus on that. I don't know that there's a case whether it's associated with viral load. There isn't enough evidence right now to say, well, if you have above a certain viral load, you are going to become more severe. Not clear yet.
Thanks, Trevor. Indeed, I think there's still a lot to learn, and that's why we promise to keep on bringing this platform to keep ourselves updated with the recent developments. We, as usual, acknowledge all the questions that are in there. I may just want to let you know that I think we have most of the answers to all the questions that have been asked in the previous sessions, and we should be sharing these soon. We will try to make sure that each and every question that has been raised on this platform is received its response it actually deserves. So we will be posting, we have already posted videos, recordings for these sessions on our Outbreaks webpage that I've put on the screen right now. So you'll see our COVID-19 diagnostics page. You will find all the videos there. In a couple of days, we're going to be uploading all the slides and questions and answers to these previous sessions and the ones that will be coming as we move on. So please visit our site, become an ASLM member if you have not yet joined, and we promise to keep on bringing, I think, all these experiences until we win this war. As Trevor put it, it's wartime COVID-19 testing. I also want to announce that tomorrow we have another exciting session. We bring our DA manufacturers, we bring Abbott as well as Biorad company, and they will talk to us about the technologies that are offering right now in this fight. This will be the third set of our manufacturers, and we shall continue to bring them here and there as we continue to move on. Trevor, I would like to ask you in 30 seconds to just give your final remarks.
Thank you, and thank you, everyone. I think in a few months or a few weeks' time, we will be need to look back at the the COVID response and look carefully at our testing. As you know, in every country, testing becomes the hottest topic, and there's focus on: are we getting enough tests? Are we doing? How many tests are we doing? Is everyone getting tests? And also, test turnaround time becomes part of national news, and it's presidents and ministers of health talk about it. And so, I think as the nucleic acid testing moves to even higher scales and higher levels, I would say be prepared that it is going to become under the spotlight. And so it will be very, I think, important in light of that to really focus on the turnaround time and getting results back, and of course expanding capacity so that it doesn't become a too hot a topic to handle. So thank you, everyone.
Thank you, Trevor. We also appreciate you taking time, and I'd like to thank everyone who took time to come and be with us this afternoon or this morning or this evening, depending on wherever you are. We appreciate all of you. And till we meet again tomorrow, same time, it's goodbye for now. Thank you.